Welcome to the NEI podcast. This is Dr. Sabrina Siegel with the Neuroscience Education Institute. Since its inception in 2000, NEI has distinguished itself from other continuing medical education companies by providing the highest quality, visually engaging, evidence-based, and fair balanced activities designed to help keep you on your A-game when it comes to treating patients with psychiatric and neurologic diseases. NEI was founded by award-winning psychiatrist Dr. Stephen Stahl, who had the desire to help more patients by helping the professionals who treat them. I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and welcome to the NEI podcast. Today, I am interviewing Dr. Thomas Kosten, and we are discussing the opioid epidemic. Dr. Thomas Kosten is the J.H. Waggoner Chair and Professor of Psychiatry, Pharmacology, Immunology and Neuroscience, Vice Chair for Psychiatry and Co-director of the Dan L. Duncan Institute for Clinical and Translational Research at Baylor College of Medicine. He is the founding Vice Chair for Addiction Psychiatry of the American Board of Psychiatry and Neurology and past president of both the American Academy of Addiction Psychiatry and the College on Problems of Drug Dependence. He is a Distinguished Life Fellow in the American Psychiatric Association and a Fellow of the American College of Neuropsychopharmacology. He has served as a Congressional Fellow in the U.S. House of Representatives and has been a long-standing member of various substance abuse commissions for the National Academy of Sciences, as well as various advisory boards for the Food and Drug Administration and Department of Defense. Dr. Kosten, can you share with us a little bit about what clinicians might be able to do to help this situation?
Well, the most important thing that they need to do is to recognize patients who have opiate dependence as a problem. This is a particular issue with chronic pain patients who, if they've been treated with opiates for more than 3 months for some type of benign chronic pain, they may well have developed some of the aberrant behaviors that go with addiction. They all, by that time, are very likely to be opiate dependent in terms of physical symptoms, and the management of them may, in fact, have gotten complicated by that factor. That is, with the chronic pain management using opiates, you've got 3 things that are contributing to making the pain worse rather than better. One is tolerance. That is, it takes more and more opiate to get the same amount of relief. The second is hyperalgesia. That's a phenomenon that occurs in about half of people who are chronically put on opiates, where minor pains are greatly magnified so that they become major pains, even though they're minor. The third thing is that opiates, particularly morphine-type opiates, stimulate the pathways, the inflammatory pathways through the TLR4 receptor in inflammatory cells, releasing a variety of cytokines that produce inflammatory pain. So if you have a condition that inflammation is an important component of the pain syndrome, and there's a lot that's true for, your opiates over time will actually make that worse. So recognizing that at the get-go, making an accurate diagnosis, one that in fact doesn't avoid opiate use disorder as a diagnosis, but acknowledges that might in fact be an issue, is the first thing.
What is the relapse rate for opioid addicts who do not go on maintenance treatment, and what would you say are some of the most effective maintenance treatments available?
The use of opiate detoxification as a first step to treatment is critical, particularly if you're going to use an opiate antagonist like naltrexone. However, it's not essential in that methadone maintenance and buprenorphine maintenance will in fact allow people who are in opiate withdrawal to get relieved of that opiate withdrawal by giving the buprenorphine or the methadone, and then they go on to a maintenance state with that. However, if you just detoxify somebody, and meaning that you discontinue the opiate in the hopes that they will then go on to remain opiate-free, that is generally a lost cause. The relapse rates within 2 weeks run about 35%. The relapse rates within 6 months remain about 80%, and the relapse rates within a year are about 90%. So there may be 10% of people who for a year or so can remain abstinent, but that usually involves a variety of special situations, such as they may have gotten their opiate withdrawal treatment in a residential treatment program and may in fact have stayed in that residential treatment for anywhere from a month to 6 months, and those are special settings that will reinforce abstinence. If you're going to do that transition from opiate dependence onto either an opiate-free state or preferentially onto an naltrexone, then you should be aware of lofexidine. It's a new FDA-approved medication that will, in fact, allow you to reduce the symptoms fairly substantially and get somebody onto naltrexone with various techniques as quickly as 3 to 4 days rather than the 7 to 10 days that it indicates in the PDR.
That was going to be my next question, was about lofexidine, which was recently approved by the FDA. How does this treatment compare with other treatments in terms of effectiveness?
The lofexidine or the other?
The lofexidine.
Yeah. The lofexidine, there's no other FDA-approved treatment for opiate withdrawal other than methadone and tapering down methadone. The other commonly used approach is to put people on buprenorphine and then taper down the dose of buprenorphine. Neither one of those are terribly effective. Many people, as they get to the lower dosages of either methadone, which would mean anything under 25 milligrams a day, or buprenorphine, which would mean anything under 2 to 4 milligrams a day, often simply can't tolerate a reduction beyond that and end up long-term on the drug. But that's the place where lofexidine would fit in. And lofexidine is similar to clonidine. Clonidine is an antihypertensive like lofexidine, but clonidine has a variety of side effects from the standpoint of medical withdrawal, in that it causes hypotension, it causes sedation, and it causes the provider to have to adjust the dosage during the detoxification fairly regularly, usually managing the blood pressure as a sign of whether you're giving too much clonidine, as much as 3 times a day. So it's a complicated procedure. The dose ranges are quite wide, from anywhere of 0.3 milligrams a day up to 1.2 milligrams a day, depending upon the severity of withdrawal symptoms. Lofexidine greatly simplifies that because it doesn't produce much orthostatic hypotension, if any, is not sedating. It's actually given at a fixed dose for the period of the medical withdrawal, which is usually about 7 days, 5 to 7 days. It's been used in Europe for over 20 years, been given to 500,000 people over there, and is the standard of withdrawal for Europe. The FDA has obviously been a little slow in approving it, but it is approved now, and certainly would be the recommended approach to medical withdrawal.
When we talk about maintenance treatments, what would you say is the minimum amount of time that someone should be on such a treatment?
It's pretty clear from the studies that have been done with methadone maintenance, which is something that we've had since the 1970s, that a minimum period of 2 years is needed on these medications to change all the psychosocial factors that are involved. The biology can change a lot faster than that. That is, the acute withdrawal is obviously going to resolve in 7, 10, maybe 2 weeks. There's then a protracted withdrawal syndrome that can go on for several months. But even when that protracted withdrawal syndrome is resolved, and the protracted withdrawal involves trouble with sleeping, trouble with concentrating sometimes, and a general kind of uneasiness and craving for drugs, but as that resolves, it still takes longer. Why is that? Most people come to treatment after 8 to 10 years of using these illicit opiates. In that period of time, they've gotten a lot of the wrong kinds of friends, a lot of bad habits, a lot of employment, legal, family, psychological problems that don't resolve quickly. So not only do they need these medications, but they're going to need counseling. And usually that's something that's going to occur once a week or so, and it's going to be directed towards fixing all of those psychosocial issues that have come up in their lives. And usually a 2-year period is what it takes, so that if you look at people who have been on methadone maintenance for at least 2 years, and you look at their outcomes 5 years later, their outcome compared to people who've not been on for 2 years is substantially better. I mean, at least twice as good in terms of pick any outcome you want, whether it's psychological symptoms, crime, opiate use, infectious diseases and other medical disorders. everything gets better. Can you, in fact, be on these medications like buprenorphine or methadone for the rest of your life? The answer is yes. And on methadone, there are probably 15 to 20% of people who have started on methadone 40 years ago and are still on methadone at relatively low dosages, usually around 25, 30 milligrams, not the usual methadone dosages of 120 or so, because they appear to have what might be a metabolic disease that's an opiate deficiency disease or something.
Wow.
And when they're on it, they're fine, and when they're off it, they're not. There's no reason you can't stay on these medications for long periods of time. There have been plenty of follow-up studies of their medical consequences, if any, and all the medical consequences, by the way, are typically positive. That is, liver function improves, there's no long-term renal consequences of being on these medications, and certainly the risk of overdose from using other medications, particularly opiates, of course, is substantially, if not completely eliminated at the higher dosages of buprenorphine. The only drug that can, in fact, override buprenorphine's blockade is fentanyl, and that, of course, is a current problem that we're facing.
Yeah, that actually leads me to my next question. Can you tell us a little bit more about the fentanyl vaccine that has been effective in animals? Can you explain a little bit how that works?
Sure. The drugs of abuse in general are way too small to provoke antibody responses. So in order to make these drugs into something that could provoke an antibody response, these drugs of abuse are attached to what's a carrier protein, a protein that does produce antibodies, like tetanus toxoid, like cholera toxin B, and a variety of other proteins that are out there that do produce fairly substantial antibody responses. When you attach these drugs of abuse to these other proteins, to this tetanus protein as an example, your body then makes antibodies not only to the tetanus, but it also makes antibodies to the drug of abuse. These are highly specific antibodies, and what they do is when the antibody encounters the drug of abuse in the bloodstream, when somebody uses the drug, either orally, smoking it, intravenously, however they take it in, the antibody attaches to the drug, and then the drug becomes part of a very large protein that can't get into the brain, can't get into the heart, basically can't get out of the bloodstream, except in two places, which is your kidney and your liver. And in the liver, when it gets off, it is metabolized into an inactive substance, and those inactive substances do not bind to antibodies, because as I said, antibodies are highly specific. And when it gets to the kidneys, of course, it just be excreted, either the drug as a whole, or of course, when these metabolites reach the kidneys, they'll also be excreted that way. So the mechanism is in many ways fairly simple. The challenge is you have to get the antibody levels high enough, and that has been our challenge for the last 25 years, getting those antibody levels high enough. So we now have new what's called adjuvants, which are ways to produce much higher levels of antibodies, and new carriers that we're using, proteins that they're attached to, that are now making our antibody levels, they appear to be as much as 6 times higher than the early vaccines that we had, which the early vaccines that we had against cocaine and against nicotine didn't pass muster with the FDA because an insufficient number of people reached these high antibody levels that we needed. About half of them did in most of the studies. With these new carriers and new adjuvants, we think we can get closer to 80 to 90% of the people to reach these high antibody levels, which means when the antibody levels are high, these are blocking medications.
With that, who would you give the fentanyl vaccine to? And I know you talked about this in your presentation a little bit. Who would be an ideal candidate if we had the fentanyl vaccine for humans?
Fentanyl vaccine, like all of these substance abuse vaccines, are therapeutic vaccines. They're not designed as preventative agents. So you really want to target them towards people that have a problem. But they're also competitive, which means they're competitive antagonists. You could override them if you work hard enough at it. So when you take these vaccines, if you want them to be effective, they're not going to be effective for blocking somebody who's bound and determined to override your blockade. They have to be used as relapse prevention agents. So preferably the patient has been abstinent for a couple of weeks, and then the vaccinations are going to take 2 to 3 months in order to get those antibody levels up. So you have to have some way that you're going to retain them in your setting to give them the repeated vaccinations, which will be anywhere from 3 to 4 vaccinations. They will then reach peak antibody levels at about 9 weeks or so after the initial vaccination, and they will last at high levels for probably about 3 months. At which time they're then going to need a booster to get the antibody levels back up again, because using the drug of abuse will not push the levels back up. It's not like an infectious disease, where with an infectious disease, if you've been vaccinated, as soon as you get exposed to that bacteria again, the antibody levels go up. Drug of abuse does not push the levels up. It's the drug of abuse attached to the protein that does it. So you have to be boosted. So it's a therapeutic vaccine. It's a therapeutic vaccine for people who are motivated to want to stop using. It will block usually 2 to 3 doses of street doses, that is, of these abused drugs, but you can override it. Now, the one thing where probably it could block a lot more than 2 to 3 times a abused dose is with the fentanyls, because the fentanyls are in fact highly potent drugs, which means very tiny amounts gives a overdose. So what we found in the animals is that we can in fact prevent overdoses in the animals with the fentanyl vaccine at dosages that are typically 10 to 20 times what would be a therapeutic dose, which is about all you could hope for from a vaccine. So in contrast to other drugs where we don't think we could really do overdose prevention with them. If you took a big overdose of cocaine or amphetamine with our vaccines, the amount of antibody we would need to block all of that would be substantial, and probably more than your body could actually make. But with the more potent the drug is, better we can do with vaccines. So it's very different than many other medications where the higher the potency you're trying to block, more likely you're not going to be able to block it. Vaccines, exactly the opposite.
Thank you so much, Dr. Kosten, and thank you for tuning in to this episode of the NEI Podcast. This episode has been brought to you by the NEI Prescribe app. The most powerful tool for your prescribing arsenal is here. Based on the best-selling Prescriber's Guide, NEI Prescribe app gives you access to full prescribing details, including expert tips and pearls, more than 140 psychiatric drugs, and with the unique filter feature, you can identify treatment concerns specific to each patient in order to generate a customized list of possible medications to review. With full prescribing details for more than 140 psychiatric drugs, the NEI Prescribe app could help you in your practice. Go to www.neiglobal.com.